The Association of the American Medical Colleges estimates that by the year 2034, the United States may face a shortage of up to 48,000 primary care physicians. Even now, gaining access to primary care is very challenging in Salt Lake City because the supply of primary care clinicians has not kept up with the population boom along the Wasatch Front. Finding quality medical care can be particularly difficult for members of the LGBTQIA+ community, especially in Utah, because many providers don't have experience treating these folks. As a primary care physician who specializes in LGBTQIA+ health, I am one of only a handful of physicians in Utah who offers this care. Unfortunately, there are not enough clinicians who are adequately trained in this field, which means that for those who identify as queer, which is a synonym I'm going to use for LGBTQIA+, because I like reclaiming this word, and LGBTQIA+ can be a bit of a mouthful, may not be getting the health care they need and deserve. Until I started seeing these patients, I had received no formal education, either in medical school or residency in queer health. Now, however, it constitutes about 70% of my clinical practice. How did I get here? Well, in my third year of family medicine residency, I was given an opportunity to see a patient for gender-affirming hormones. This individual had previously been seeing one of my colleagues who was decreasing her clinical time and needed to find providers in our clinic who would be willing to see her gender-diverse patients. Looking back on it, I balk at the idea that she had to find providers who were willing. Shouldn't all clinicians be willing to meet with a patient and to help them in any way that they can? We never ask our colleagues if they are willing to see a patient for their blood pressure or to manage their diabetes. But when we're advocating for our queer patients, this is often necessary because there are providers in every specialty and from every state who will refuse to treat LGBTQIA+ people regardless of their healthcare needs. I saw my first patient for gender-affirming hormones in 2011. Since then, the number of providers who offer gender-affirming care within our clinic has dramatically increased. We have intentionally recruited colleagues trained at our program and other family medicine residencies who are passionate about providing culturally competent, evidence-based, whole-person care to anyone, regardless of their sexual orientation or gender identity. But hiring new faculty who are knowledgeable about queer health isn't enough. We feel an obligation to the medical students and residents who pass through our clinic to provide them with the necessary knowledge and skills to care for medically underserved populations. To that end, we make sure that our resident physicians and other learners participate in clinical experiences and receive education on all aspects of queer health, so that every family physician who graduates from our program has a strong foundation in these areas. This education includes, but is not limited to, being able to provide HIV PrEP, which is a highly effective method of preventing HIV, as well as gender-affirming care, including hormone therapy, to any adult who needs it. Sadly, not all medical educators agree about the importance of queer health, and so this training is not uniformly offered to all primary care residents across the country. As a result, there are many communities where queer folks find it next to impossible to find a provider who has been adequately trained to meet their needs. What makes LGBTQIA+ healthcare so different from other primary care medicine? The answer is nothing. The medical knowledge that is needed to care for queer folks is essentially the same as we learn for heterosexual and cisgender populations. Many providers are already offering gender-affirming care, although they may not think of it that way. We refer patients to plastic surgeons for breast augmentations and reconstruction after cancer, And we treat cisgender men for low testosterone. And we provide postmenopausal cis women with hormone therapy. Although perhaps unintentional, picking and choosing which genders or orientations we affirm is discrimination. And there is no place in medicine for discriminatory practices. Prior to the coronavirus pandemic, I would routinely see patients who were driving 14 hours round trip for a 20-minute office visit, all because there were no providers in their area or their state who were willing to see them. At the height of COVID, the rise of virtual visits and telehealth improved access to these services so that these patients no longer had to make such a long trip. Since the pandemic emergency ended, however, I no longer see patients in surrounding states via telehealth. Luckily, a few providers have emerged in Montana, Wyoming, Idaho, and Nevada who have recognized that this medicine isn't hard, and that with some additional training, it is possible to provide comprehensive primary care to queer folks, and that if they have questions, they can always reach out to someone for help. I got lucky, and an opportunity to provide this care fell into my lap. I recognized that I didn't know enough, and so I made a choice to seek additional education about queer health. But this shouldn't have been a choice I needed to make. Queer folks deserve culturally competent, evidence-based healthcare practiced by clinicians who will treat them with dignity and respect and who are knowledgeable about the medical topics that are relevant to them. Most medical schools and residencies don't offer sufficient training on queer health, especially gender-affirming hormone therapy. And so providers like me must seek additional training in order to provide high-quality care to this community. This education should be a standard part of any medical training. But we have to do a better job than we are currently doing when providing this education. All too frequently, medical students and residents will learn about queer patients in a lecture where, for instance, the clinical case may state, a gay man presents with a rash and is later found to have syphilis or HIV. Rarely, if ever, does the case language state, a heterosexual woman presents with joint pain. And if it did, stating the person's sexual orientation draws our attention to their sexual practices and encourages us to assume that the origin of the disease process, which the case is illustrating, is related to their sexual activities. We need to recognize that all people, not just those who identify as queer, are more than just their sexual orientation or gender identity. We all experience the ups and downs of life. And like everyone, queer folks have high blood pressure and diabetes and low back pain. It is time that we incorporate queer identities into every aspect of medical education. But rather than pathologize their sexual practices or gender journeys, we need to acknowledge and celebrate their queer identities, and then incorporate them into clinical cases about low back pain, because everybody experiences low back pain. We need to move past being LGBT friendly and move towards being LGBTQIA+ competent. If you are a medical provider and you want to improve the care that you're offering to the queer community, seek out articles, medical conferences, or webinars to expand your knowledge. If you are already providing care to queer patients, offer to serve as a mentor to a colleague who is eager to increase their knowledge and skills on topics related to queer health. If you are a patient who needs this care, see if your healthcare provider will consult with someone else who is more fluent in this area of medicine while still offering to see and treat you. If you are a parent of a child who identifies as LGBTQIA+, please hug your kiddo and celebrate their courage and bravery by telling them that you love them unconditionally and that you are proud of who they are, inside and out. If they have medical needs related to their queer identity, ask your child's primary care provider for local resources that will support and affirm their authentic selves. Remember, we as physicians took an oath at the beginning of our training to first do no harm. The medical needs of the queer community are very similar to care that we are already providing. We can continue to keep this oath by expanding our scope, increasing our knowledge, and growing our skills to serve this deserving yet underserved population. No one should have to travel 14 hours for a prescription, whether for blood pressure or for HIV PrEP or for hormones. There may be a projected shortage of primary care physicians, but there does not have to be a shortage of evidence-based, culturally competent healthcare if we broaden our knowledge base and are willing to provide it. Because we should be, and we can be, and we must be willing to provide it.